So as Liz said, my name is Vara Glatt, and I actually work in San Antonio, Texas. Not American, clearly. You can tell by my accent, but I've been there for many years, and I've been doing orthopedics for about, I'd say about 18 years. I'm aged myself, clearly, now, and know a lot about bone, actually. I've studied from all points of view, mechanics and biology, and hopefully a lot of it would complement the first talk that Alex gave, and I will give you something else to think about and consider, because a lot of these concepts that even Stefan Perrin, they are good, but they're very vague. You know, how do you, in the surgery room, how do you make that your fracture initially fixed and there's no more than 10% strain? It's impossible. You can't do it, because unless you measure it, then there is no way to measure it. So hopefully you can kind of start to think about from different point of view and see how it works in a better way. So I always want to start with a couple of quotes. One, ignorant of motion is ignorant of life, and then life requires movement, and that's true, because same applies to bone, because bone is a dynamic tissue, and it really needs to be loaded in order to do anything, to heal, to remodel, anything else. And if you don't, as you know, when astronauts go to space, when they have these G gravities and they're not loading it, and they come back with basically osteoporotic, all of them, and it's very difficult, and it's very clear. So even when the fracture heals, it needs to be loaded, and if it's not loaded, it's not gonna heal, and that's why we get non-unions. Well, that's not right. There is a problem with well, hopefully it's just the only issue. So what I wanted to say here is that you can see the successful bone healing actually requires, it depends on the synergistic approach between biology and mechanics. And I'm sure most of you in the room have a decision, what's more important. You hear, you fix it, you have experiences, some of you don't yet, and you kind of on the offensive side, and you don't know what's more important. Is it mechanics or is it biology? Can you change biology, or does biology influence mechanics? So you have to think about it. And to me, and I'm sure if I took a poll, the raise of hands, who believes that mechanics is more important than biology? Come on, don't be shy. Who thinks that mechanics is more important? Who thinks that biology is more important? So that synergistic approach, and now so mechanically, interfragmentary movement, that up and down that Stefan Perrin decided, it depends really on that. It's the most important factor, accordingly, mechanically. And that depends on the fixation stability. So now if you fix it, so there is different ways to fix it. You fix it with a plate, you reduce it, there is not that much strain. And it's technically supposed to heal through that primary healing. It doesn't always, if you look biologically at early points, even with the plate fixation, there is always a tiny transition of that cartilaginous tissue, but it's very little, and you would never see that on the X-ray in the clinic. So now if that motion is a bit larger, no more than 10%, that's the school of thought, that's what we taught by Stefan Perrin, we should get that nice callus formation, and a lot of times you get it that either the plate is not quite fixed, or the fracture is not reduced, or with a nail. That's the most common way to get it, or even with maybe external devices like splint and all that stuff. Oops, sorry. But if the fixation is either too flexible or too rigid, and in this case, seems like it was too flexible, the healing might fail. But now you have to think about it. First of all, what would that mean? Does it mean that if you have 15% of micromotion, not 10, would that fail? Or would that come to heal? And how do you measure that in the clinic? So the concept is a little bit flawed in a way. So here, all these people contributed to improve and optimize mechanical healing. We know that AO's teaching was initially rigid, compressed fracture, but it didn't turn out. So then they started changing plates, changing implants to see, because they had a lot of non-unions. Then relative motion, they said you need to build the callus. That's the best way and the fastest way to heal bones. Then again, Goodchip and Kenwright from Oxford here, they also promoted that axial micromotion, because that's the best way to heal bone. Of course, different implants, Michael Botling, the cortical locking screws, active plates, and I'll show you some examples later. Of course, Elizarov tension, and that's what you came here to learn and do and how to fix it, and dynamization. And the dynamization is probably the most controversial subject until I came around and I tried to change it to see it's not about dynamization, really. It's about understanding what dynamization does and looking carefully in the literature to learn why it is so controversial and why it doesn't work, and in some studies does work. So we'll cover that. So here's what we do. So all these classical considerations over 40 years, this is what we know. We have to look at the bone quality, fracture characteristics, and geometry, and we want to then choose how to fix it. Here is fracture reduction, implant choices, implant placement, and that is all in your hands. So you choose whether you reduce it, how much you reduce it, and whether you choose to fix it. And then, of course, we have lots of choices from unicortical screws, bicortical screws, from plate length, from plate material, from distribution of screws and how many screws and what type of screws, and the length of fracture, and of course, most importantly, bone quality. And what happens if we don't choose it in the right way? What happens? It might fail. And those are the failure options: plate failure, screw breakage, varus collapse, varus malunion, and screw pullout. So you have to be careful and arrange your construct in such a way that actually do avoid all these complications. So here, just one example. So what happens when you have a lag screw and you do it in the you go across perpendicular to the fracture line? You have a really nice interfragmentary compression. So you would be compression now. If that area starts to heal, how would it heal? It's compressed, it becomes rigid. You would assume that it should remodel and be that bone. Now, if you do it across to the axis of the long bones, this is what you get. It says that it has maximum resistance to shear forces produced during that axial movement, loading. So you have to think about it. Where do you do it and where you apply it in order to successfully heal those fractures, because you can have both options and when you do it. Here, now, it says that if you have a long plate and you have screws distributed in such a way, you have really high stress concentration, so you'd want to avoid it because that probably your plate would break. Now, the suggestion is, and that was AO teaching, that you want to, if you have, when bridging these type of fractures, you want to have a long plate and spread out the screws away from the fractures because that would reduce those stresses. But is it okay? Do you think that fracture would be stable and actually the patient went on to heal? What do you think? Maybe you have to add screws closer to the fracture so it provides a bit more stability. So those are the choices you have to make every time you do it. And you have to learn and you have to consider and think why you choose specific situations. Now here, biology also, you have all these options, biological soft tissue, you have to consider for those, and it was already covered. But to me, the most important tool that drives that biology, and you can be fixed, that magnitude of strain, because that would determine you build callus or you don't build callus, and loading conditions, which is it axial, is it shear, does it introduce any rotation? Does it do anything, displacement? So you have to think about all of this, and what happens if you do that? So the most common ones, atrophic and hypertrophic non-union. So what does happen? So hypertrophic non-union, here you have it. So what do? Why did it fail? You look at the plate configuration. I'm not a surgeon, I don't do this but I have a mechanical background. From a mechanical point of view, to me, if you look at it, to me it looks like that plate could have been much longer. If you had that plate longer, you maybe would have fixation. Now, how do you fix it? As I told earlier, what if you add 2 lag screws? If it's hypertrophic non-union, you should easily to consolidate. You change the mechanics, so you use those strains, just like I showed it here. It compresses that fracture site really hard, and then because it already has callus, it doesn't need any more micromotion because it's counterproductive. In order to have vascularized bone and cartilage, hypertrophic non-union has vessels, of course, but it doesn't really because they keep getting destroyed. Because if it did have a lot of blood supply, it would be turning into bone. And it doesn't until you reduce strains, and once you do so, that's what you get. Now, what would you do? That's maybe not your choice, and I'm not educating to do so, but that's what you have to consider. Nails, of course, when you nail, you have lots to consider. It's said to be that it provides that relative stability, which builds that callus, and a lot of times you see it in there. So what do you consider? Goal is, of course, with the nail, as every other implant, to realign, have alignment, and the rotation of the limb, and not anatomical reduction. So because you can't reduce it as well as you can reduce with a plate. Diameter, of course, important, whatever you choose. It's load-sharing but not load-bearing device accordingly, and that's all AO teaching, so you have to think it just all from the literature. Ideal for femoral and tibial diaphyseal fractures. What do you choose? And of course, correct entry, that's even more important. So you want to make sure, don't create a bad situation if your entry is not correct. So you're gonna, again, no matter how many screws you add later, and if it's perfect, it's not gonna be appropriate and maybe not gonna heal. You guys here got together looking at, again, many choices to make when you build your frame, whether it's for traumatic injury, whether for lengthening, and you have to decide pins and how does that affect mechanically all your frame. Pins, half pins, wires, how many rings you're gonna use, how far apart from that osteotomy line you're gonna have it. All these things to consider. If you use distraction osteogenesis nail, again, you have to control distraction. You could failure of that rotational stability could be a problem, so you have to think how to avoid this. Premature consolidation as well, if you're not lengthening enough, it's gonna consolidate too fast, and then it's again, you have to create another osteotomy and so on. And of course, you get poor quality regenerate, and that's a problem, right? So you have to consider all these situations to know. And what does cause that poor bone formation? So it could be very factors, or first patient-related factors, and a lot of times you hear orthopedic surgeons tend to, oh, well, I put the perfect frame and the patient is just not compliant. But is it really? Do you allow yourself to think that maybe I didn't put that plate, and why you put that or plate or nail or even a frame, why do you put it in such a way? And does it make sense mechanically to do so? So you have to constantly question yourself. Don't just learn to learn because somebody told you to do so. Ask yourself why you do it certain things in a certain way and understand it. Because it could be many reasons, like latency gap, of course, as you see it here, from these iatrogenic factors, unstable frame, again, and how to avoid that. Short latency period, you have to wait long enough. Too fast distraction, too rapid distraction, you maybe slow it down, but again, then you have to look at the patient, so you have to have that balance. If you have a smoker or you have a osteoporotic patient, your distraction, as you know, because you were taught, it has to be a bit slower, so allow that bone to form because the bone is poor quality. But why do you do it? Because you have to allow for that bone because it takes a long time. It's like being older, it takes for you, once you're walking from point A to point B, much slower than you would be when you're young. You can, go faster. So it's the same happens with bone. You have to think about it as a living, breathing organism, right? And here are all these stimulation techniques. And while they do help, and we have biologics, and we have biometals nowadays, and we have physical stimulations that we can apply when we see that regenerate is not going, but why we doing this way? And really, once you do it, it really doesn't change that much. That regenerate does not consolidate much faster. You maybe gain 2 weeks, maybe 3 weeks, like a bit slower, but do you want to do it better? Do you want to do it really fast and rapidly? And that's what you have to ask yourself. How do we optimize it? So fixation optimization, here's a plate came up called active plate, never made market. It was tested in animal models. I know animals are not humans, but it was tested, and that was done in the sheep. And here's the active, so it was compared against compression plate versus active plate. And it has that silicon mechanism that supposedly allows a little bit more micromotion, conceptually. And it does allow, and as you can see, if you look at the fracture, the way it heals, comparatively to compression plate, we definitely get that bigger callus formation, and it's right here. But the problem is, it didn't heal any better. It still looks the same. Why? It didn't demonstrate it, and in fact, when they start testing in patients, they pulled it off the market. They shelved the product because they didn't send. And the problem is, and again, I'm going to get to it specifically in my second talk, you have to think about it because that is micromotion, and how long do you need it? Just because you have micromotion doesn't mean you need it forever. So you have to think about timing, and I think that's what, so far, most of us and most of the literature never considered timing. Maybe 10 years ago started to think about timing. When do we need what type of micromotion to optimize that healing process? So you have to think, maybe flexible is good earlier, but we don't need it so much later because once you have that callus, you don't need it. So here now, screws, where do you put it? Each screw adds mechanical integrity, that's for sure, in terms of axial and torsional. For bending moments, spread of the screws, each range priming seems like the way you spread them out is much more important. Flexion extension, you can't think that if you add more screws that somehow it's gonna magically make it better. You have to be clever about it. You're not gonna get necessarily, and look at this, that's not necessarily gonna give you the best outcome. So we did a study looking at different configurations, and that's in extreme, and that was actually a segmental defect that we looked at it. So we arranged the screws in different positions, like as you see here. So that's the typical teaching, right? Most surgeons, once they know, they say, oh, you have to spread them out. You have to have a long plate for maximum stability. And as you can see it here, we kept this constant, and it's constant. And it's actually, there's a theory. So once you have put in one fragment, specifically distal fragment, there's a mathematical theory that once you have so many screws, it's called crowd theory or something. So they act as one big screw. So that makes sense, you put it in. So what is best, right? You keep constant the distal part, so what is the best screw configuration? If you think about it, how would you fix it? Well, it turns out that there is a special configuration whether you have, based on the normal osteoporotic bone, quality plays an important role regarding the risk and construct failure. So there is a sweet spot. Apparently, no matter which one you use, this configuration turns out mechanically be the best. When you have a long plate and spread it out in the proximal segment, spread out the screws. And that really seems to apply to a lot of different mechanical things when you fix the fractures. So ideally, and I'm sure most of you are gonna say, what, 2/E? What does that mean? So apparently this is what you have to do. Ideally multiply length of proximal segment, so you can count proximal segment by 2/E. And that should be the ideal length of the plate that you have to cover from that proximal end. And that's how, and you practically distribute. So practically you just distribute all by 4. So here, let's just do a little bit of a math game. So that's how you determine, right, in the fracture. So this is your proximal segment. 1/E. Not the best way, but that would give you pretty good mechanical integrity. What is E? I'm sure most of you. It's Euler's number. So that Euler's number, 2 points, if you only remember 2.71 or 2.72, that's good enough. So you have 1 divided by 2.7 times 5, because that's your segment. That's your segment. And that's how you get it. That's how far you at least that much have to cover with a plate from that one proximal segment in all directions. And even better is if you do much longer plate. That's 2/E, so you cover much faster, and then you are mechanical, and then you spread the screws evenly in the holes available. Of course, you can't do it perfectly because it depends on the plate. Here's if you have here a bit more comminuted fractures, the same principle applies. Again, you look at that proximal segment, that's already would be good. And I showed you earlier, that caused somewhat, because it wasn't covered enough, the plate was not long enough, it caused hypertrophic non-union. So maybe you're better off if you do 2/E, so you have a much bigger, and again, it's 2 divided by this number times this number, from basically your fracture line to that, and you've been doing this, measuring that alignment, mechanical, anatomical for your corrections. So that's what you have to start thinking. You go before in the OR, you know the fracture, look at the X-ray and try to think how much you're gonna cover, which plate you're gonna choose, how long the plate's supposed to be, and how you're gonna cover screws. The same works here. But here, it's a bit trickier because then, is it most mechanically stable frame? Probably not. Because if you wanna do it, you would technically, if you choose, here again, you choose the points, you wanna take it in the middle. But is it the best way? Because in this case, this is lengthening, so you probably thinking about soft tissues, and then you have to spread it out this way. So you have to compromise. Then you make certain things, additions, wires and rings, they spread out the rings to make sure that that's mechanically correct. If you choose 2 rings to do, again, it would give you similar stability, but again, you have to divide it by half, those 2 points, and then those 2 rings should be distributed from that half in equal distance. And then, of course, you consider if you use wires, so or half pins, then you decide how many of those you have to use. And again, I'm not going to teach because you've been going through that class. I'm just giving you the concept and understanding. And this frame actually is mechanically the most stable, right? But again, you can't do it in every situation. So you have to think balance. Balance is the best. What are you doing and why are you doing it and what do you need to achieve? And that's what you have to think. Just don't learn and blindly do something just because somebody told you to do. Think about it, why? Now, that's my favorite part. So potential to modulate that mechanical conditions around the fracture during healing period. Dynamization. Everybody knows dynamization. It's controversial. People believe it, people don't believe it, and I think there's going to be a lot of talks about it. What do we do? Do we know when, how much, how long, and do we even need it at all? Because traditionally, if you read the literature, it doesn't seem to help. It does in some studies and does it in others. So before you think about dynamizing or not dynamizing, you have to think, what is the purpose of callus? And you know that you want, so the fastest way to healing bone, to create that little callus formation, right? If you do it. So then, the callus only responsive to those initial first weeks because biologically, you have the hematoma, and your micromotion determines how much that the hematoma spills out. Imagine like the gluing two pieces of wood together. So you put the glue in between, and if you squeeze it a lot, it's going to spill out on the edges. If you squeeze it a little bit, it's going to be less. So that determines your basically the callus frame, how big or how much. So once you have that unstable fixation, you become with that big callus, right? And it doesn't heal, but you get like that huge callus. Now, the problem is with dynamization. So once your callus appears on that X-ray, it can increase in size. And not always you can see it on the X-ray if it's not mineralized. The callus could be already there, but just because you don't see it, it doesn't mean it doesn't exist, because it could be there, but it's not mineralized. So if there's no mineral there, then you can't see it on the X-ray. So if you think about it, if you already have callus early on, and you think about dynamizing 2-3 weeks later, it would seem to be counterproductive because like, you don't want that callus to grow. You actually want to start now consolidating. So why would you make it grow anymore? So why would you dynamize it? Because dynamization is having rigid first and then making flexible later. So here's the literature. Not huge, but pretty much all the literature up until I think 18, all on dynamization studies. Green worked, yellow didn't make any difference, and red didn't work. Actually, in fact, was detrimental. Why? We know one thing that all these studies agree that flexible fixation promotes callus formation. So they all agree that if you make it flexible, it promotes callus formation. If you have too much that flexibility, these high magnitudes, it would inhibit bone healing. So we all agree too much. But this is what they find, early versus late dynamization. Some studies said that it was faster healing times. Some studies say that it does not change non-union rates. Time to union was significantly longer in some studies. When they late dynamization, they said some was beneficial, failed healing if dynamization was longer than 6 months, and time to union was longer. So very controversial. Here a little question about the nails. Here, there's a nail. Came on the market, I don't know even one. Suddenly came nice brochures, dynamizing nail. They made this slot bigger. Now, how would you fix it? You have now this tool that it says dynamizing. What do you do? And distal part is most important. Do you use both holes to fill right away, or do you wait? How do you do it? Because it changes. So if you use that hole and this hole, your dynamization doesn't exist. It's not flexible anymore because you fill both the holes. Now, if you don't fill this one, you can somewhat make it flexible, but it matters. If you put it right closer to this edge, imagine patient is walking, it would start compressing a bit more. If you put it on that edge, right here, it's probably going to pull a little bit more. And if you put it in the middle, it kind of does in between, so it doesn't really help. So you have to think about it, how you do it and why you do it, and just because there is a fancy fancy nail out there with a great brochure, it doesn't mean it's doing anything what you want it to do, and you have to think why you should do it. So what do we do? Dynamize it or not? Here's the problem with the literature. That's why it's confusing. So there's two types. One that does axial collapse. So what they did, basically the collapse. And the second one, elastic one. So it has that spring response. So it goes down, whatever you allow, let's say 2 millimeters, and comes back again, and goes down and comes back again. And here's the problem. That's the biggest confusion, why some work, why it doesn't. So if you do it, and I will come back, I guess, to it, but that is not dynamization, really. That makes it more rigid. So it reduces strains when you do this type of dynamization. But here it doesn't. That provides micromotion, so it would be completely different healing. But if you look in the literature and don't look at it carefully, you don't recognize that those are two types of dynamizations and people using it. So what do we know, actually? Too rigid, constantly, not too rigid is not good, so we don't want it too rigid. Not too flexible, because again, it could cause issues, non-unions. We know that mechanical conditions drive biological response. We know that axial micromotion stimulate callus formation. And we know that it changes actually over time. Like I said, time is very important when you do it and how you do it and why you do it biologically to influence that better healing response. Here, and actually, your callus will tell you what mechanical conditions you have. If you look at the X-ray, you have a bit this type of shape, like a kind of sand shape. You know that it's pretty rigid fixation. And I just maximize it to make it semi-rigid. You get like a little bit swelling. And if it's micromotions, you get that little kind of onion shape that you see it in the nails. So you get micromotions. So here's my idea was, what if, because we know biologically that we require initial micromotion, the fastest way to stabilize callus. Now we see that callus on the X-ray, that cloudy, nice. We don't need it anymore. That means we need to make it rigid so we can vascularize and remodel into bone. Because the more, if we continue to flex it, it's like hypertrophic non-union. If we continue to be cartilage, and we would have trouble to actually converting it into bone tissue. So I call this reverse dynamization because it's the opposite of dynamization, where you initially rigidly fix and then make it flexible. This, you provide flexibility because that's what biology requires initially, and then make it rigid because it doesn't need it anymore. Once it builds that callus, you don't need it anymore. So here's a perfect study that demonstrates, and I have a couple more slides and I would end. There's a perfect study demonstrates. So we did at 2 different sites in Germany. Lutz Claes, that was mentioned earlier, he's one of the biggest biomechanic bone healing professors in the world, actually. So here we did 2 studies, we collaborated. So we did dynamization here, and here reverse dynamization. So what we did was, the control groups, right? So rigid and flexible fixation. Everybody heals in about 5 weeks, thereabouts. So here what's happened when we actually dynamize it after 7 days. I can't say, yeah, 7 days. It completely was detrimental to heal, so we had it rigid for 7 days and then changed it to flexible. Look what happens. That's a clear non-union. Look what happens when we reverse dynamize it. We allow that little micromotion, right? And then we made it more rigid. Look what happens here. It starts to remodel. If we do it at 14 days, it's even better. So if we allow that micromotion for 14 days and then change it to more rigid for the remaining 3 weeks, look at this. It starts to remodel and close those cortices. So it's clearly better, and that shows very clearly you have to think about the timing, when to apply specific motion and how much to do it to get successful healing. There's the most interesting result. When reverse dynamization or dynamization later on in this specific model, after 3 weeks and the remaining 4 weeks, we found basically no difference between the two, and that makes sense. Because now we're talking about, as was mentioned, Wolff's law, right? So now the frame very little contributes. The majority of the load goes through these to actually through that bone. And fixation device does not contribute very much. So that's why when you read literature, and if they did late dynamization, it was no difference, because it makes sense, because that frame does not contribute anything anymore to the overall stability of that fracture. And in the early days, that's when it's really important. And here, just to show biologically, right, what happens once you have it so flexible, and of course, external frame that you use in these animals is not super rigid. So you get like, even in the rigid more, you get little cartilage. By 28 days, it's much less than in this one. But look what happens when we do reverse dynamization. 14 days, flexible and then rigid. You completely, there's basically completely healed and remodeled into tissue. I mean, he still needs to remodel, but it's completely gone. So if you allow just a little micromotion early and then change it to more rigid, which just allows that vascularization to come in and doesn't disrupt that vascular supply, then you get that nice healing and that optimized healing. And you probably could avoid a lot of these non-unions. So here I want to leave you with a thought, because a lot of us get stuck in these concepts that we were taught, and we don't know even why we're doing it. And often we become very rigid. So don't be one of those people. And that's Max Planck, with his German physicist, said, the scientific truth does not triumph by convincing its opponents and making them see the light, but rather because its opponents eventually die and the new generation grows up that is familiar with it. So whether you're old or young, no matter who you are, don't be rigid. Actually think why you do what you do and apply your knowledge and question everything you do. Just because you're taught by somebody doesn't mean they did it correctly, or doesn't mean that that's the new way of doing something. So I'd like to acknowledge this and thank you for your attention.